Okay, so my name is Brian Donovan, head of pricing in the healthcare pricing office. I think a lot of talk in the conference to date has been around, how we pay for good quality outcomes. I think the important thing underlying quality payments would be that we've good data to underpin quality payments. So my talk will cover just some of the issues we've dealt with in the last couple of years around trying to improve the quality of the data from an ABF perspective. And obviously, if we can do that from an ABF perspective, that benefits everybody who uses the data. So you'll have heard there's different groups using it, and Deirdre's presentation will cover that. Jackie will follow up in more detail around some of the quality tools that we use around verifying the quality of the data. So what have we done in the last 2 years? I'll try and just cover it on a general basis because we've done a lot, but also conscious that that we've done things on the coding side and on the costing, and just pull it all together. So the quality agenda. So why would we improve our data quality? So we cover that. What has changed? So we've done a national audit of admitted data. We've implemented patient-level costing program. One of the things that we've done, particularly Maureen's mentioned already, is our ABF monthly reporting, and I really see that as a very useful tool going forward to improve quality that is very timely, and I think James mentioned the importance of timely data in the process. I'll just touch on our audit program, the other things we've done, and some of the next steps. I would like to thank my colleagues Mark O'Connor and Donovan for putting together some of these slides. So I thought as well, we'd start with looking at the healthcare pricing office. We actually do more than just pricing. So I try to break it down into some of the things we do around data collection, data validation, analytics and development. So there's a lot going on, and one of our briefs is around data quality, which is why the things we do is about trying to improve the quality of the data that underpins the funding system. I think, the funding system, certainly in other countries, tends to drive the quality of the data when there's payment on it. And as I said earlier, that benefits all the users. So that's the home of the HPO. We've a home gig today. So I think if you look out this window, you'll see our offices. I think that photograph was probably taken on the grounds here. So that's where we hang out. So just some of the facts and what we cover. So within the ABF arena, we have 38 hospitals. I think as Lee mentioned earlier, we deal with 1.7 million admitted patients in ABF. There are 1.2 million ED attendances and 3.5 million OPD attendances that are happening in the hospital system, but at the moment fall outside of the ABF arena. Obviously, the intention going forward is that they would get engaged, because I think once you have everything in, it tends to improve the quality of the costing data as well, because there's no incentives to cost elsewhere. So our policy objectives, again, very similar to James's slide. I mean, I think internationally, this is typically the reasons why you bring in ABF. But within the policy paper in Ireland, there is a line around that any ABF system must support delivery of quality care in the most appropriate setting. So quality does feed into everything we do. And I think, to be fair, I think we have to get the funding system up and running first before we can, start looking at quality initiatives. Although Maureen has mentioned one where we'll start looking at around lap colis. Data quality, why and where. So pretty much data underpins the allocation of the ABF funding. We obviously want to ensure that there's an equitable allocation. So obviously, if there's poor coding going on, it means somebody's not receiving the appropriate level of funding while others are. Because if we're distributing a pie, then everything gets allocated. Good quality data is good patient care. Rick Marshall, who would have done some work from us from Australia, basically said, the corollary of that is, poor patient records is poor patient care. So I think that's an important thing to bring, because a lot of focus is on coded data and how well data is coded when we analyse it, but really the coders can only code what's there. So there is certainly that engagement between clinicians and coders around just the information that's put in the chart and how readily available it is for the coders. I've also mentioned about, we have to look at the quality of the data before you bring in quality measures. Deirdre will cover the other users of ABF. So where is the data? This is a slide we've taken from the patient-level costing. So I think it's quite clear that data is everywhere in the hospital, and what we're trying to do between the patient-level costing and the coding is to pull all that data together to allow us to get good patient-level costing, to allow us to get an appropriate price. So they're all the components. You can see they're quite quite substantial. We do have a problem with lack of systems in certain hospitals around patient-level costing, and I think there are certainly areas where we can develop. But like everything else, I think you have to get started. But that essentially is where the data is coming from. What is ABF? This is just for people. I was conscious of the audience will be varied, so quickly run through what ABF is. It's essentially funding patient care, not institutions. So we're looking at the activity hospitals carry out rather than the institution itself. What is it not? I think we have to be very careful about this. When Maureen was on the roadshow around, there was an expectation that it was going to deliver everything, including fixed budgets, reduce overruns. So we had to be clear that it wasn't a panacea for all ills in the health system. It is essentially about distributing the funding. But as I said, the benefit of that is that we get good data that can be used for other parts of the health system. Currently, it's inpatients and day cases. And that accounts for about 70% of our expenditure. So Maureen showed the slide where essentially we had 3.2 billion under ABF. The other areas of OPD and ED, as I say, form the block, and they're still funded within the block. So just the components, where are the data pieces that we're using? Activity information comes from the HYPE data set. On the costing side, we have two forms: specialty costing, which 38 hospitals carry out, patient-level costing, which we've implemented in 19 hospitals. And Fiacre and his team put together the price setting, which is really pulling all that data together. So really, we have a number of components feeding into our price setting piece, and the importance for us is that the data underpinning that is solid and robust. So activity information, our HYPE data set. So again, this is what Deirdre side doing the organisation. It's about taking the 1.7 million records that I mentioned earlier. Every patient is discharged to one and only one DRG. It's coded onto HYPE. It's returned to us. We check it with our quality tools, which Jackie will outline. Each month, the hospitals return data to the HPO as part of the process, and that data then is used when it comes to the funding system. So we have your 12 months data. Validation is a key piece of the work of the HPO, and that process of doing that monthly is important from the hospital's perspective, that everything gets coded, particularly when I come onto the monthly reporting piece where we're trying to monitor your performance. If there's uncoded cases, it really limits the benefits of your monthly reporting. DRGs, just for people who aren't familiar, it's basically about assigning patients based on the complexity of their case. So we have each DRG is similar from a clinical perspective and cost. As James mentioned earlier, it's important we have a manageable level of DRGs. Otherwise, you're moving to a fee for service. So what you're trying to do with a DRG system is have a manageable number that's administratively feasible. Our classification system is Australian, 807 DRGs. We've up to 4 severity levels in different DRGs. We did change to version 8 this year in 2016 in our process. So the whole complexity basis on which that was dealt with changed, and Brian will cover that in his presentation this afternoon. But the importance of severity levels is the key thing around quality of the data. It's important that you get your case into the appropriate DRG. So that's the structure. So there's a kind of structure around how the numbering is applied. E is the specialty, 65 determines that it's essentially a medical patient. So you know by the numbering what specialty, whether it's a medical or surgical patient. And A there is the complexity. So the A is the most complex patient, and obviously we pay the most for an A. So the importance of coding, I've mentioned some of these, is about that the codes represent the treatment the patient has received, so we can pay the appropriate payment. So the other thing that's important is that the chart documentation reflects it, because the coder is not allowed to code what's not on the chart. Even if they think something should be on the chart, they can't there, and it's more mentions if it's not in the chart, it didn't happen. The coded patient then that's returned each month is essentially the invoice for us. So this is what you've done, and we then pay that. I'm not sure if that's difficult to see, but essentially that's the stroke patient where this patient is 51 days. So straight away you'd probably say that's a high costing patient. But if you get the wrong DRG assignment and don't assign enough diagnosis, you could end up getting a payment of 5,000 when you should be getting a payment of 23,000. So that was important. And when we started looking at the data set 2 to 3 years ago, we seen this in a hospital, and this is a similar one to Maureen showed. This hospital was below the national average. So that got us thinking, well, if that's happening in one adjacent DRG in one hospital, what's the likelihood of that happening across the system? So that's when we started looking at, we need to do this on a national basis to underpin the commencement of ABF. So this was conducted by Pavilion Health, a national audit of admitted patient information. We only reported last October, although the process would have commenced in 2014. The tender requirements when we tendered in 2015 were around a review of our full year's data set. So that was a comprehensive study. We also wanted to look at the financial effect. So could we actually estimate the financial effect of undercoding? It's easier to identify above average coding because there's additional diagnosis there to detect that. Trying to detect below average coding is a lot more difficult because you have nothing there to assess. So we had a detailed benchmarking process that we used to compare hospitals against their peers to determine what the financial effect would be. We did chart-based audits. We also wanted to look at best practice so we could apply that around the system, and also what were the appropriate training requirements. So there was essentially a four-fold approach, and some of that had helped to our advantage. The fact that we had to tender meant we weren't going to tender for each component, so it was actually, we did 4 together, which I think made the project because we were able to verify the findings from different angles. I think it was a unique piece of work even internationally that nobody had gone at it from this four ways. So the findings were that we had a sound basis for the introduction of ABF. We obviously did see variation, and part of the work was where was that variation, what specialties was it happening in, which hospital, and could we build that into our training. There is obviously evidence of best practice in a number of hospitals. So some of our hospitals here were actually coding up to the same level of Australian hospitals, which was really good compared to the fact that we've been doing DRGs less in Ireland and Australia. We did compare our data with Australia, with 2 states in Australia to get an international benchmark. So we did find that we were lacking specificity in certain specialties like respiratory and. So we also did find that where there was good coding, what were the key things we were seeing where there was good coding, and certainly the big thing was where there was higher levels of direct coder integration with the consultants. And I think that piece became clear. We did do individual hospital reports to hospitals, we reported back to each hospital their findings, met with the hospitals, so we met with 32 out of 38 hospitals to go through the report. And that became clear that there was a correlation between clinical involvement and also the quality of the report. Managers had more time to do review, so this idea of just coding and sending it in to us without reviewing it, certainly not the way to go, and that's why we've looked at funding a resource at group level around the coding. Obviously the services that used our tools for quality checking, and we can obviously check which hospitals are using our tools because every time you log on, it's notified. So that was certainly something that was very useful for us. We got some recommendations both at hospital level and national level recommendations, which we're now implementing. And part of that at hospital level is that you've all got a work plan to look at the issues that the reports address in your hospital, and Cliona does follow up with you on that. We as a group nationally are looking at the recommendations from our perspective and are working on those. So some of the hospital specific ones are around coding resources, and we've certainly we're putting more resources into the hospital system around coding. I think it's about another 20 coders have been added, which is about 10% of the workforce. Coder access to patient charts, use of data quality tools. Nationally, there's been more resources at the HPO around trainers and auditors. So again, everything linked to improving the quality, increased education, improved clinical engagement, and obviously training development. So that's just some variations in the coding that came from the report. So clearly, the hospital on the very left, we're under coding to, that's 3,000 weighted units. We pay 4,500 euros per weighted unit, so it's probably about 12, 13 million below average coding for that hospital. The flip side is the hospital on the right is above average coding. So at the moment, we will be underpaying the hospital on the left and overpaying the hospital on the right. So really what we're trying to do with the study is get the hospital on the left up to the line, which will automatically pull back the hospital on the right. They were just some of the DRGs where we've seen the big impact. So the AO6, the tracheostomy was the big area. So as well as giving a report back to the hospitals around the specialty, we were able to drill down to the DRGs. In fact, you could go down to consultants around which were the consultants. So that was an important piece of work for us. We have done some work here then as well around looking at improving the specificity. So you can see there's certain DRG here. Pointer. There. This one here for E75. We can see that this is comparing the hospital against the national. So we can see for E75, the hospital went from 43% when the national was 56 to now that is 56% for the hospital versus 55% nationally. So we can see that the coding is going up at hospital level, but it's also improving at national level. And that's typically what we're finding. So in the past 2 years, and even in our work on the ABF, we have seen that some of the hospitals who were over on the left are beginning to get their coding in order and coming back to the centre. That is the update on that hospital. What we showed earlier on the stroke, the B70A. So that hospital who had 4% of strokes in 14 now has 20%. So clearly they've got their coding up to speed. But you can see that the all hospital ABF average has also increased. So, but it's a better picture for us from a funding perspective than it was 2 years ago. And we're seeing that in a number of the other specialties which were highlighted by the report. So on the costing information, we have 38 hospitals providing specialty costs, starting with the annual financial statements. The underlying principle is obviously matching costs with activity, and the output from these files determine, our ABF expenditure within the total expenditure in the hospital. Patient level costing, we implemented this over the last 2 years in 19 hospitals. After a tendering process, Power Health Solutions were the company who were successful. So we have a national license, but we've installed it in 7 groups. And we use the PLC data, patient level costing data, to calculate the price. And that's important because we're getting Irish data setting Irish prices. And they're the 19 sites that we've implemented. So it's right around Ireland and also different type of hospitals, obviously the cluster around Dublin. So again, patient level costing, it's a very new concept. We're seeing variation in the quality of the costing depending on the number of feeder systems that the hospitals have. But I think it's an area, we have to improve the data there. And I think part of that was that we would also, look at setting up a patient costing users group, which would, assist the users and share knowledge. So PLC is essential for ABF. You can't have it. And it's not just for us to set prices. I think the key piece for patient level costing is for hospitals to understand their performance in the hospital and be able to compare their cost with the price we pay so they can actually start investigating why. And you'll find length of stay typically is a key driver. But unless the data has been used at hospital level, practice isn't going to change. So we can change the funding system all we like to move from block to an activity-based, but if it's not happening at ground level, on the front line, it's not going to work. So I think there is an onus around us providing the data to the hospitals initially, because I think it's a new area. We have a lot of skills in our organisation around the analytics, and I'll cover that in the monthly reporting. But the data has to be acted on. It's no point data being generated, sent into us for prices. We set prices, give it back to you. You're not going to see any improvement unless it's used. Obviously, what we do on the pricing shouldn't do anything that negatively impacts on clinical practice. So obviously there's a lot of benefits from patient level costing. Peer benchmarking is a key one, and I think this is something we're about to tender for, to try and give hospitals again the tools. So when they're doing their costing and they look at the cost of a hip replacement and they look at the different cost buckets, they're able to compare their costs at the different cost bucket against their peers to see where am I more expensive. Is it the prosthetic or is it the nursing cost, which is pretty much driven by length of stay. So it is about trying to, get the tools out there, but they have to be used, and that's the key piece for us. Patient-level costing should also improve your clinical coding, because if you have, a patient, that previous example, who was in for 51 days, they're going to have a very high cost. Now, if you haven't coded that correctly, the price you receive for that patient is going to be well below the cost. So straight away, when you do your service line reporting to compare cost and price, that should be a big negative for the hospital. So I think the tools are there. It's about just getting hospitals to use them. Certainly the benchmarking process we see is a key piece to give the hospitals some tools to benchmark against. I mentioned the Patient Costing Users Group. Mark O'Connor chairs that. Mark's been recently appointed Head of Costing in the Healthcare Pricing Authority office. So, sorry James, I'm taking your piece. So that group, as I say, is to develop and implement consistent methodologies for our costing and to discuss our findings and what hospitals are doing. So John Cotter from St. James's will present on what they're doing in their hospital. And somebody mentioned earlier about barcoding, so I think John's presentation will actually cover where they've barcoded the theatre to get better costings, which again feeds into the price setting process. Our monthly reporting, and this is a key piece of work. And I think, the evolution of the hospital groups has created more requests for data at group level. And we've had requests for the hype data at group level so we can do our various analysis. And really what we're trying to do is to point people towards our monthly reporting. So if we can build it in the group's requirements into the monthly reporting, every group gets access to the same type of data set. We then also have everything benchmarked, compared back to the data that goes to Maureen, that goes to Liam, that goes to the groups, and we don't have to be reconciling our lives away. So it is something we've met with a number of groups. And I'll cover some of the slides that we're showing, but I do see it as the key way because it's timely, it's every month. Obviously we have a 30-day coding lag, but so we're basically operating 30 days in arrears. So we are looking at activity, so we're comparing, have you actually carried out the activity that you were contracted to do? We then look at the expenditure and say, okay, if you've carried out that activity level, have you done it within your expenditure level? So we're linking the activity with, have you got an overrun in doing that? And also, we have an issue about breaking down expenditure between block and ABF, but I think it's very useful to just see, okay, if a hospital is ahead of their target, what's it doing to their expenditure? So we're linking activity with funding for the first time. It's a single tool for multiple hospitals. So essentially, it's a click-view document. Everything sits in that document, and just different people have different access. So obviously, ourselves in the HPO and Q Finance have access to everything. The hospital groups can see all their hospitals in their groups, and obviously the hospitals then have access to their own. So very much drill down capability then, which we'll cover. So that's just an overview of how well you can see that. So Clean actually is in the room beside here at lunchtime or afterwards, after lunch. If somebody wants to get a view of what we actually do, I've knocked out figures here, but pretty much it's when you click on the first sheet, you get an overview of your hospital performance or group performance. You can see straight away, am I ahead of target, behind target, how does it link to expenditure? Have I got uncoded cases? Because uncoded cases is certainly an issue for us now. I think James mentioned that as well. To get the data timely and for it to be useful to a hospital, you have to have everything coded. We look at expenditure versus activity. So again, we're able to say, are you ahead or behind on your expenditure, depending on the activity you've done. We can drill down to see if we are ahead or behind. Is it inpatients, day cases? We even have same days broken out because obviously medical assessment units are a big issue now, so they were distorting some of the inpatient figures. You can look then at some of the drivers, what's driving your change, which inpatients are driving it, so you can pick your DRGs that are driving it. We can look at the complexity over time, so again, you can see what your complexity was for 16, 15 and year to date. If you're behind in your complexity, you can drill down on that to see which specialty is it. You can drill down to see which consultant. So I think it's a really rich data set that's consistent, and that you know that the data in this is the data that you're being viewed at a monthly performance meeting. So the benefit for us is that if something is generated that has a hype on the bottom of it, we don't have to, reconcile that data, and can you verify that data has come. So I'm really pushing this as a, as a solution for the group requirements around reporting, and certainly we're meeting with groups, and we will, follow up on that. We've also looked at complexity against peers. So that previous slide that we showed from the national audit, which showed the variation in coding, that's built into the monthly reporting now. So you're getting an update on that position for your year to date. So again, you can see where, are you still behind, which DRGs and which consultants. So there's a drill down to consultant level there. So just some of the audit program. Again, we're conscious that to improve the quality, if people know they're going to be audited, then that brings more, certainly we think it's improving quality. Certainly in the costing side, the purpose of these audits is not like a revenue audit where we're out to find 20,000 or we settle for it. It's really educational. So it's really to see how you're doing things. Are you doing it primarily in accordance with the standards first? But if we see something that you could be harming your hospital or not costing correctly, we'll tell you as well. So our objective, is to ensure the best quality data. We're not out to kind of say, you shouldn't be costing your ABF this way. It's really to try and get you costing correctly. So we've carried out 8 last year in advance of the ABF benchmarking process. Our program is designed to do it over 2 years. Every hospital will be audited over 2 years. So really, our purpose is to ensure better quality data. On the coding side, again, we're developing a program for that. Jackie will refer to that in our presentation. So essentially, 16 clinical coding audits took place in 15-16. 4 have been performed year to date, with 3 more scheduled at the end of June. And again, on the ABF hospital side, we're trying to get every hospital over a 2-year period. So, and they will be coordinated with the costing as well. So I think, this piece around improving the quality of the data is high on our agenda. There's a data quality strategy in preparation that Jackie's worked on. And some of the, certainly within the HPO ourselves, we're looking at having a data quality group that straddles not just the coding, but also the costing, patient level costing, and indeed the pricing. So just some other changes, just comes to time. Certain resources have been provided around the ABF area, so both for HPO and the hospitals themselves. So we've, in the HPO, we've got hype trainers in now. The new people have started, auditors, IT, and accountants. So again, we were lacking in resources in that area to improve the quality and carry out more audits. The hospital groups, and again, have got additional coders, group ABF accountants, group hype managers, data extract staff. They're all in the pipeline now, I think, ready to go. So again, that's designed around giving the people, the groups, the skills to monitor the data we're using and act on it, because I really feel, us producing the data and nobody looking at it is wasting our time. We've increased coder training and costing training. So next steps, our ABF education program is in development, and again, that was an output from the national audit. So that will look at not just coders, but obviously the different people in the hospital and groups. So if you're an accountant or if you're an administrator, to give people an understanding of ABF, how it impacts on your funding, and the importance of having good data, because it will, as I said, your monthly data is your coded data is your invoice. We will go to tender for a patient-level costing benchmarking system to allow the patient-level costing hospitals compare themselves with their peers. Likewise, for a data activity quality system. So again, we get regular reports, almost daily reports on the quality of the data. And the final thing we were doing is just, again, timeliness of the data is important for certainly the costing side, and we've run into issues in that in the past. So we will improve the timelines for the collection of costing data through penalties for late submission. So that's all I have to say on that overview. I think Jackie will follow up now just on the tools that we use for the data quality.